Hello and welcome to this video series where we will be going through the Omaima notes, which is one of the most important study notes for the Mrcs Part A exam. So I will be going through all these bullet points, and it is assumed that you have gone through all the syllabus and it will be just for the revision purposes. At the end of each video, I will be providing you with a certain PDF which you can use in collaboration with these notes to develop your visual memory. So let's get started. So first branch of internal carotid artery is the ophthalmic artery. We know that the internal carotid artery is going to give different branches. The first branch is the ophthalmic artery, and then it is going to give the anterior cerebral artery, it is going to give the middle cerebral artery, and it is also going to give the posterior communicating artery. So out of these, the very first branch is the ophthalmic artery. These two are the terminal branches, and this is one of the other branches. Numbness over the lower lip after tooth extraction is by inferior alveolar nerve. So it is very important to understand the sensory supply of the face. We can relate these MCQs of the sensory supply as well. So here we have that the numbness at the chin is by the mental nerve, which is branch of the inferior alveolar nerve, which is actually a branch from the mandibular branch of the trigeminal nerve. So next sensory question is that the numbness over the cheek is by the infraorbital nerve. Nerve supplying the forehead above the eye is by the supraorbital nerve. So above the eye, supraorbital. Numbness over the lower lip. Lower means inferior and lip has a different word, that is the inferior alveolar nerve. So numbness over the lower lip in addition to paralysis of the muscle of mastication would be by the mandibular branch of the trigeminal nerve. So these MCQs are very important, and when you are going through these MCQs, try to use plate number 2 of the Netter's Atlas, though I will be providing its picture in the form of a PDF so that you can use that when you are going through these, so that next time at the end of the month, at the end of your exam preparation, you can only go through these pictures and you can revise all the knowledge. Okay. So next up we have that the loss of the general sensation from the side or anterior of the tongue. So regarding the tongue, we can divide it into its motor innervation and the sensory innervation. Now all the muscles are supplied by the hypoglossal nerve except only one muscle, that is the palatoglossal muscle, which is supplied by the vagus nerve. Now in terms of the sensory innervation, it is further classified into two parts, that is the anterior 2/3 and the posterior 1/3. Now in both posterior 1/3, the sensory plus the taste sensations, both the sensory and the taste are by the glossopharyngeal nerve. So regarding the anterior 2/3 of the tongue, it has two separate innervations, that is the sensory and the for the taste. Now for the sensory supply of the anterior 2/3, we have the lingual nerve. For the taste sensation from the anterior 2/3, we have the chorda tympana. So next up we have that the nerve injury related to the submandibular gland. So we have two scenarios for this. Now submandibular gland injury has already been established, and what is the clinical picture? The patient developed tongue deviation. Then the answer would be hypoglossal nerve. nerve injury during submandibular gland surgery near its duct, then the answer would be the lingual nerve. So we know that with reference to the submandibular gland, we have three nerves which can get damaged. So first of all, we have the lingual nerve. Second, we have the hypoglossal nerve. And third, we have the marginal mandibular branch of the facial nerve. So these are the three nerves which are important with reference to the submandibular gland. Most common nerve injury in the cavernous sinus. We have the abducens nerve. Now, abducens nerve is not only affected in the cavernous sinus, it is one of the most common nerve which gets affected in the injury to the brain area because it has one of the longest course. CNS tumor with vagus and glossopharyngeal nerve palsy. So site of compression would be, so they are testing you for the knowledge that from where does the 9th and 10th cranial nerves are taking their origin. So for that we have the medulla oblongata. So we know that the first and second nerve originate from the cerebrum. Third and fourth is coming from the midbrain. Then the 5, 6, 7 and 8 are coming from the pons. 9, 10, 11 and 12 is coming from the medulla. So next question states that which cranial nerve that does not have the parasympathetic fibers? That will be the optic nerve. We know that the 3rd, 7th, 9th and 10th cranial nerves are the nerve which are having parasympathetic fibers. For this the mnemonic is 1973, where this one corresponds to 10. Okay. So level of compression of the 3rd cranial nerve, that is the oculomotor, would be in the midbrain. We have gone through this part as well. So with increase in the intracranial pressure, which nerve will be affected? We have the abducens nerve. So if there is any cavernous sinus pathology, or there is increase in the ICP, or there is some brain injury, we will have abducens nerve as the nerve which can get injured. So the reason for this is that because it has the longest course, and long course make it more susceptible to get more injured. So single test to differentiate between the upper motor neuron and the lower motor neuron lesion of the facial nerve is the inability of the eyebrow elevation. Nerve injured during parotid gland surgery is the facial nerve. We know that facial nerve, in addition to the retromandibular vein and the external carotid artery, are the component of the parotid gland. And out of these, if they are testing you for the nerve, you will be going with the facial nerve. And if they are asking you for the drainage, then retromandibular nerve can get damaged, and the vessel which can get compromised or which can bleed would be the external carotid artery. But there is a catch over here, that facial nerve is injured and passing through the parotid gland, but it is not supplying the parotid gland. Nerve injured during parotid gland surgery, which results into drooping of the lip and resulting into asymmetrical smile. So now they're not only testing you for the facial nerve, as we know that the facial nerve is going to branch into its 5 branches within the substance of the parotid. So the one which is going to result into drooping of the lip would be the marginal mandibular branch of the facial nerve. So we have this nerve which can get injured in both the parotid as well as in the submandibular gland in surgery. So nerve injury during superficial dissection of the parotid gland, that is the great auricular nerve. We know that the sensory supply around the ear, lower end of the ear, and parotid gland is by the great auricular nerve. So as it will be encountered when we go through the skin and superficial fascia, it will be encountered in this part over the parotid. So it has to be safe. So for the parotid, the nerve which can get injured during the surgery when you are inside the substance of the parotid, that would be the facial nerve. And if it is asking about the superficial nerve, then it will be the great auricular nerve. So hoarseness of voice is by the vagus nerve or the recurrent laryngeal nerve, which nerve give motor supply to trapezius and sternocleidomastoid. We know that it is the spinal accessory nerve. Spinal accessory nerve is the nerve which is present in the posterior triangle of the neck. And if there is any surgery in association to lymph node dissection, especially in the posterior triangle, then the nerve that will be damaged will be the spinal accessory nerve. So what will be the clinical picture? Patient will be unable to shrug the shoulders. So patient presented with torticollis, in that also we will have spinal accessory nerve involvement. After end arterectomy, the patient developed deviation of the tongue. We have learned that the motor supply is by the hypoglossal nerve. So whenever there is deviation of the tongue, we will be choosing hypoglossal nerve. So numbness at the angle of the lower jaw is by the great auricular nerve, which is having its origin from C2 and C3. All of the following are passing through the superior orbital fissure except. So the answer would be the ophthalmic artery. We know that ophthalmic artery is going to pass through the optic canal. And what are the structures which are going to pass from the superior orbital fissure? We have the cranial nerve 3, 4, 5 and 6, and out of this fifth cranial nerve, only the V1 branch will be passing. Now in addition to these nerves, we will be having superior plus inferior ophthalmic veins, which will be the component of the superior orbital fissure. So we have discussed this. Now maxillary artery passes through the foramen rotundum. Mandibular nerve is passing through foramen ovale, and maxillary nerve is going to pass through the jugular foramen. So next up we have that the middle meningeal artery is going to pass through the foramen spinosum. Internal carotid artery is going to pass through the foramen lacerum. Hypoglossal nerve passes through the hypoglossal canal, which is present in the anterior condylar foramen. Ophthalmic nerve passes through the superior orbital fissure. So just an overview that from which area which other structures are passing. So for the foramen ovale, we have the mnemonic, that is ovale. For the O, we have the otic ganglion. For V, we have the V3, that is the mandibular branch of the trigeminal nerve. For A, we have the accessory meningeal artery. With L, we have the lesser petrosal nerve, and we have the imagery veins. From the foramen spinosum, we have the middle meningeal artery. From foramen rotundum, we have the V2, that is the maxillary branch of the trigeminal nerve. And from the foramen lacerum, we have the internal carotid artery. From optic canal, we have the optic nerve plus ophthalmic artery. Now, structures passing through the superior orbital fissure, we have the third cranial nerve, fourth cranial nerve, V1, that is the ophthalmic branch of the trigeminal nerve, and the sixth cranial nerve. Now, in addition to this, there is going to pass the superior plus inferior ophthalmic vein. So, ophthalmic artery is going to pass through optic canal, but the superior and inferior ophthalmic veins are going to pass through the superior orbital fissure. So, from the carotid canal, we have the mnemonic, that is the side, and out of this, S represents sympathetic plexus. Out of this, the most important is the internal carotid artery, and then we have the deep petrosal nerve and the imagery veins. From the jugular foramen, we have the 9th, 10th and 11th nerve which are passing. From the stylomastoid, we have the facial nerve and the mastoid artery. Now from the foramen magnum, we have the lower end of the medulla oblongata, which is going to move downward. And then we have the spinal root of the 11th cranial nerve. And we have the vertebral artery, the anterior and posterior spinal arteries as part of it. So next up we have that the cerebropontine angle lesion, which is the nerve that is going to be affected. So we know that at the cerebellopontine lesion, we have the 5, 7, 8, and the acoustic neuroma will be the diagnosis. So if they're asked about the nerves, it will be the 5, 7, and 8. And if they have asked you what is the name of the lesion or what is the pathology, in that the answer would be the acoustic neuroma. So a patient is hit on the vertex, which is the top of the head. Which sinus will be affected? We will be having the superior sagittal sinus. Vertebral artery is a branch from the subclavian artery. We know that the subclavian artery is divided by the anterior scaleni into three parts: the first, second, and the third. The first part is going to give the VIT, and then the C and the D. So mnemonic is vitamin C and D. So we will be having the vertebral artery. With I, we have the internal thoracic artery, and with D, we have the thyrocervical trunk. With C, we have the costocervical trunk, and with D, we have the dorsal scapular artery. So next up, we have that the vertebral artery is going to pass through which area, and that is the foramen transversum of the C6. We know that the C7 does not have this foramen transversum, so it is going to start from C6 and ascend upward. So the area that it will be starting would be the C6 vertebra. Fracture of the middle third of the clavicle. Which vessel is affected? We have the subclavian vein. Branches of the internal carotid artery. We have the anterior cerebral and we have the middle cerebral. Apart from this, we have the posterior communicating artery, and we have also learned that the first branch is the ophthalmic artery. And we also know that the ophthalmic artery is going to pass through the optic canal. So next question is that the stroke of the anterior cerebral artery is going to cause or represent lower limbs will be the affected area. So they can ask you a scenario in which they have mentioned internal carotid artery, and they will say that this is the clinical picture. So in that case, you will be selecting the anterior cerebral artery. In other case, which is in this, they will give you that the patient developed stroke and the artery that is involved is the anterior cerebral, and what will be the clinical picture. So these questions can go both ways. So you have to be prepared for that. So nerve that is not contained in the posterior triangle is the ansa cervicalis. We know that the ansa cervicalis is present on the anterior aspect and it will be present in the anterior triangle. So regarding the posterior triangle of the neck, it is formed anteriorly by the posterior border of the sternocleidomastoid that will be forming its anterior border. Now, the posterior border is formed by the anterior aspect of the trapezius muscle. So do not get confused about these. So remember that for the anterior and posterior borders, we have opposite names and you need to remember the muscles. For anterior, we have the sternocleidomastoid. For posterior border, we have the trapezius. And the inferior boundary is formed by the middle third of the clavicle. There is an important thing that the inferior belly of omohyoid muscle that is represented by this red color is going to divide this posterior triangle into an upper part and the lower part. Now, what are the components of this posterior triangle? Now, we have divided them into nerves, vessels, muscles, and the lymph node. Now, regarding the nerves, we have the spinal accessory nerve, we have the phrenic nerve, and we have the trunks of the brachial plexus. In the vessels, we have the subclavian artery, and we have the external jugular vein as part of this posterior triangle. In terms of the muscles, we have the inferior belly of omohyoid and the scalene muscles. Out of these, inferior belly of omohyoid is the muscle which is also dividing the posterior triangle into an upper part and the lower part. Now, in terms of the lymph node, we have two lymph node. The one which is in the lower part will be the supraclavicular, and the one which will be in the upper part will be the occipital lymph nodes. So now we will be going through the MCQs related to this posterior triangle. What is contained within the posterior triangle? We have the spinal accessory nerve. Phrenic nerve is in the posterior triangle of the neck. Now, during thyroidectomy, the infrahyoid strap muscles are divided where? Near their upper part. Neurovascular structures within the parotid gland is the facial nerve, retromandibular vein, and the external carotid artery along with its two terminal branches. I have discussed this part in the previous parotid gland MCQs. So next up we have that the pharyngeal pouch lies between which muscles? We have the cricopharyngeus and the thyropharyngeus. Ganglia which is responsible for the lacrimation is the sphenopalatine ganglion. Hassel's corpuscles are present in the thymus gland. Now, nucleus of the glossopharyngeal nerve is located in the medulla. We have learned about this previously. Trigeminal nerve nucleus is present in the pons. Now, what are the layers of the scalp? We have the skin, then we have the dense connective tissue, then we have the aponeurosis, then loose connective tissue, and then we have the periosteum. Now, the sequence can be asked in the form of MCQ, so you have to know the sequence that is from the skin towards the periosteum. So, regarding the dangerous area of the scalp, we have the imagery veins because they are connecting the intracranial to the extracranial area within the loose connective tissue. So, these imagery veins are responsible for the connection of the inside of the brains to the outside of the brain, and that is why the infection from the scalp can spread to the face, or from the dangerous area of the face it can spread into the brain. So next up we have that what is the sensory supply of the scalp. For this we have the trigeminal nerve. Internal carotid artery branches in the neck. I have explained that it gives no branches in the neck. However, all the rest of the branches are in the cerebral part. From the cerebral part that is inside the brain, it is giving the branches which we have learned. Venous drainage of the scalp is by the facial vein. Posterior triangle of the neck has the trunks of the brachial plexus. In addition, we have discussed that it has the 12th cranial nerve and the phrenic nerve as well. Now, subclavian contains the division of the brachial plexus, that the subclavian artery is related to the division of the brachial plexus. Now, axillary artery is related to the cords of the brachial plexus, and we know that we have the medial cord, posterior cord, and the lateral cord of the brachial plexus. Now, suprascapular and the transverse cervical arteries are branches from the thyrocervical artery. So, the subclavian artery, its first part is going to give 3 branches, that is the vertebral artery, then we have the internal thoracic artery, and then at the last we have the thyrocervical trunk. Now, the vertebral artery is going to continue upward into the brain, and it is going to contribute to the circle of Willis. Whereas internal thoracic artery is going to divide, and it is going to give the superior epigastric artery and it is going to give the musculophrenic artery. Whereas the thyrocervical trunk is not only going to give the suprascapular and the transverse cervical, this thyrocervical trunk is also giving its third branch as the inferior thyroid artery. So you need to remember that which is the main artery and what are its other arteries which are going to supply different branches. So next up we have swollen subclavicular lymph node in the neck are suggestive of the red flag of the gastric cancer. Muscle dividing the triangle in the posterior triangle is the inferior belly of the omohyoid muscle. We have discussed this previously. And what are the other muscles which are present? We have the scalene muscles. So we have discussed that which are the structures present in the posterior triangle. So let us discuss about the anterior triangle now. So the anterior triangle of the neck is further divided into three components, that is the muscular triangle, the digastric triangle and the carotid triangle. Now within the digastric triangle, we have the facial vessels. Along with that, we have the hypoglossal nerve, that is the 12th nerve. In the muscles, we have the strap muscles, all of these muscles. And in the carotid triangle, the most important structure is the common carotid artery with its bifurcation into the external carotid and the internal carotid. In addition, it has the vagus as well as the hypoglossal nerve. The 11th nerve is the spinal accessory nerve.